Okay, well, thank you very much, everybody. I'm very much going to build on what Glenn has been talking about and talk about some of the same techniques. I think for designers, we always feel, and I speak as the leader of a group of designers, engineers, architects who are based at the Royal College of Art in London, we often feel excluded from the early stages of any development or innovation project in healthcare. And we come in at a stage when, at a late stage, and in a partial way. And so my presentation is really a plea for greater involvement. You're probably wondering why somebody from the Royal College of Art is speaking. We're next door to the Albert Hall in Kensington, but 70% of what we do is design and not fine art, though we have a wonderful fine art school, but we teach architecture and product and furniture design, communication, interaction design, service design, all the kinds of things you would expect in the healthcare arena. We're entirely postgraduate, MA, MPhil, PhD, with a big body of postdoc researchers, and very, very practice-based. We make things, and I suppose I always describe the college thus: if you show a photograph like this at the Royal College of Art, everyone goes, "That's absolutely gorgeous. That is a Danish bentwood chair, made in 1953, designed by Fritz Hansen." We're very much about material things and about the aesthetics of experience, which Glenn talked about. And if our students can't afford a Lamborghini, then they will make one out of wire and send it through the streets of London and stop the traffic. And in fact, we have a long history with healthcare, going back to the 1960s, and actually being invited to the King's Fund conference today is a kind of full circle for the RCA, because we worked on the Nuffield Foundation study back in 1963, and with support from the King's Fund, this study led to several innovations in non-surgical equipment, including what became known as the King's Fund bed, which is now still in use in 85% of hospitals. Our big interest in patient safety started in 2003. This was a report the co-director of the centre, Roger Coleman, co-authored, and it was endorsed by Liam Donaldson. It was basically saying that any large organisation, like an airline or the oil industry, would have in place design systems to manage risk and error. And the NHS needed to take this more seriously. And since then, we've done a lot of work for the National Patient Safety Agency. We've been involved in the Department of Health demonstration projects with the Design Council, such as Design Bugs Out. We've worked with industry. If you look in the bottom left, for example, our work on surgical instruments with DePuy. And a few weeks ago, we launched a redesign of the interior of the London Ambulance. We work very closely with the London Ambulance Service to provide a safer, cleaner, lighter ambulance with 360-degree access to the patient. All of these things using a co-design process. And only last week, we were involved in the Department of Health. We were on the team which has been developing proposals to reduce violence in A&E. With a lot of incidences of violence and aggression, and we've developed a whole toolkit for NHS trusts to implement. The project I want to talk about briefly today is called DOME, Designing Out Medical Error. This was a collaboration between the Royal College of Art, Hamlyn Centre, and Imperial College Department of Surgery and Cancer, and Imperial College Business School. I work with Professor Vincent and Hannah at Imperial. What was interesting is we looked very, very closely at the surgical ward. We looked at surgical processes, and you can see the bay on the left is from 1948 and the bay on the right is modern day, and the design principles are little changed. And we all know, and I don't need to tell this audience, that there is a mismatch between clinical processes which are evolving quickly and rather more slowly evolving furniture and products and communications that go into the bed space. So we were looking really at taking a systems level approach to it. Critically, we wanted to take a multidisciplinary perspective. And what was interesting about this project is we formed one project team. In the early co-research phase, the front end of the innovation process from which designers are traditionally excluded. We were there, along with process and management experts from Imperial and clinical psychologists. And in the design phase, where clinicians usually drop out of the picture and designers are left to kind of figure it out and then throw it back into the clinical space, clinicians, all the players were there. We were all together in the same boat and moving forward. What we did was we triangulated a lot of data from observations, from questionnaires, a lot of published incident data, and we identified the processes with the highest risk of error. We know that 1 in 10 of all hospital admissions, something goes wrong, and we identified the 5 most hazardous processes: hand washing, monitoring of vital signs such as blood pressure, pulse, temperature, oxygen saturation, and so on, isolation of infection, medication delivery, and staff handover between shifts. These were identified. We then observed in more detail exactly what was going on, so that everybody understood exactly how we were breaking it down. And there was detailed mapping of these processes. A lot of clinicians know these processes, but designers don't. And the key thing was to get the designers to understand at a fundamental and thorough level exactly what was going on in each process within the complex ecosystem of the bed space. And we used something called failure mode and effects analysis, FMEA. It's an engineering tool. And this was the common platform around which all the different players in the project could coalesce. And this was really an important aspect for us. And doing something like this is very important for those devices in the bed space that do not require rigorous clinical trials, such as pieces of furniture. And working with Emma Stanton, I know she was here earlier today, at Imperial, we also looked at analogous industries. We put our hard hats on and went on construction sites. We went out to an oil rig. And this slide shows a mine where it says here, at Lisheen, we injure someone every 12 days. Can you imagine that on a big sign outside a hospital? They're very open about it. There's an open culture. And that was very interesting, and it fed into the process. So out of this, we developed, for each of our high-risk, error-strewn processes, we transformed, as a group, the research into design briefs, and I'll just very quickly go through. And what was critical about the whole process from start to finish was the active engagement of frontline clinical staff. We worked mainly at St Mary's in Paddington, and this is a patient and a doctor behaving like designers. Neither are designers, but they are going through a kind of design process. And the design interventions were a whole number of design interventions, one for each of the briefs that we developed. And we developed product, communication, and interaction design interventions, as well as environmental and service recommendations. Just show you a couple. The problem with monitoring vital signs is that the trolley is often difficult to clean, the cables get tangled, and documentation is difficult to plot and read, so people don't often take action on the information. So we completely redesigned the vital signs trolley, working with an American manufacturer, human scale. It's much easier to clean. Things like various devices like the finger clip are on retracting cables. And the data is automatically displayed on screen. There's no plotting, reading, or transcription errors. With hand hygiene, we know that the NPSA campaign was great to raise awareness, but the problem is still that people don't use hand alcohol gel at the right times, and there's an incredible amount of visual clutter around the gels, and we've developed a very, very simple new logo, removing the visual clutter, and it can be accompanied by a temporary campaign to let staff and patients know what the symbol is. Staying with infection, there's a problem that aprons and gloves, as well as alcohol hand gel, are seen as an interruption to more important tasks in the bed space. And around the bed space, there's all kinds of issues. And handover, staff handover particularly, is very, very difficult. very, very difficult from the point of view of rooms often being ill-equipped, too small and prone to interruption. And what we did around handover is propose a flexible multi-purpose environment which combines a staff room with a handover room. So it converts a leisure setting into a more formal setting with different light levels and different furniture. TV screen becomes a digital information board, and so on and so forth. And finally, coming back to this infection area, there are a lot of issues around medication lockers being hard to access, doctors having nowhere to put sharps when they finish with them, gloves and aprons not being near the bed, no flat surface. And what we've proposed, and this addresses a whole number of issues, is something we're calling the care centre. It's a hub for bed space activities, and we involved over 100 staff and patients during development of the first prototype, which you can see on the right. And this is it being developed, manufactured by Bristol Made. We're going through further testing, and it has a flat surface for writing, apron, gloves, alcohol gel, medication locker, wipes, and a clinical waste bin, all in one integrated unit, which just slots up and butts up against the edge of the bed. And we've put it into clinical trials, and we're getting a lot of very good staff feedback. So these are the kind of interventions that we've been working on. I'll just conclude with one very, very simple point. Although we're very pleased that some of the developments are turning into products and services and they're going to manufacture, I think the big important gain from the DOME project is a more collaborative way of working. And I liken it to moving away from the old-style relay race in developing products for the medical arena to a rowing team. So this is what used to happen, or conventionally happens. The clinicians, capture the data and the information. They capture the performance requirements. So they do the research. They run panting to the designers who pick up the baton and run off with it and do the concept development. They give it back to the psychologists and clinicians to do trials and feedback. Then business gets involved in manufacturing it. Designers are a long way from the action by the time it goes through to manufacture. And then something is built and thrown back into the clinical environment. And actually, it's quite dislocated. It's being done at pace, but it's not kind of working. The DOME methodology has proposed that we're all in the same boat together. It's like a rowing team. We're working together, learning about each other through the research, concept development, trials, feedback, and manufacture. And critically, by having business experts on board in the early stages, we were able to learn a lot from analogous industries. So that's a gallop through the project. There is a publication that you can download from our website at the Helen Hamlyn Centre. And I'll stop there and invite questions. Thank you.
Thank you.